the CSP West Midlands Regional Network. So tonight is a follow-on session. So last year we did a session on ICSs, and we've got 3 more speakers to bring it up to speed today, because also we know a lot more about the ICS than we did 12 months ago. So we're going to encourage you to please tweet your observations using the @West Midlands CSP and hashtag WMCSP. So that would be great if you could do that. Okay, so we're also really keen to try and get to 2,000 followers on Twitter. So we are 7 short. So if you're on Twitter, or if you're not on Twitter, join and follow us, and then we can get to hopefully 2,000 followers during this presentation. We're also on Facebook, and we're also on Instagram, and the details of how to follow us are there. So housekeeping. So please remember to put your microphones on mute when you're not speaking. And then the presentations from this session are being recorded and will be shared afterwards via Eventbrite, and they'll also be on the West Midlands CSP webpage, and the link is there. And I know that some of you have already looked at last year's session, because we do store previous sessions there. So if there's a session that takes your fancy when you're browsing, just please click onto it and look at us back. Please also use the chat box to introduce yourself and pose questions for the presenters. So this is just a way of seeing what questions are being put to the presenters, and the chat box will then show up at the side of the screen so that we can actually see the questions as the presentation is going on. And again, just a reminder, please use the hashtags if you're using social media. Okay, so I am Philip Hulse. I work at the Orthopaedic Hospital at Oswestry, the Robert Jones and Agnes Hunt, where I'm the therapy service manager there. And I co-chair the CSP West Midlands Network. We've got a really great core team, and if you're interested in joining the core team, please do contact us, because we're always looking for more volunteers to help run the West Midlands Network. So this evening we're going to have presentations from Simon Whitehouse, from Clare Pheasant, and from Seema Gudivada. And these sessions, during the sessions, you can post questions in the chat box, and we'll deal with questions at the end. And then at the end of all 3 presentations, we're going to have a panel discussion where people can pose questions to all 3 of the presenters. So we're looking forward to a really good interactive evening. And I would like to, at this point, welcome Simon to take the stage.
Thanks. Thanks, Phil, and good evening, everybody. And look, it's an absolute pleasure to be able to come and present. It would be great if we were in a room and able to see people and have a coffee, but the joys of Zoom and Microsoft Teams probably means we've got more people without all of the travel and without of the inconvenience of that. So, so great to be invited. Especially great to be invited, given you know, I'm a physio by background, but we'll come on to that a little bit later in a bit more detail in terms of my career and how I got to be where I'm at. So I did watch the session back in terms of that Mark Brandreth delivered with you last year. I'm going to just set some out the high level bit really of integrated care system. What does that mean? What does it mean for AHPs? What does that look like? Hand over then to Clare, who will go through into a bit more detail around that, into AHPs, into the professional side, and then through to Seema, who will get into some of the detail of the council and the framework and everything else that goes with that. But then we're more interested in getting into that conversation discussion and getting the slides out of the way and understanding where people are at. In terms of Twitter competitions, my Twitter handle's there at the bottom. So as many followers as possible. I'm going for the 3,000 number. So if people could choose to follow me and share that, that would be really helpful. And in the best Chris Whitty moment, next slide, please. And great to see people coming in the chat from the Shropshire, Telford and Wrekin patch. So delighted for that. So look, let me just come back to some basics right at the start. On the right-hand side of this slide, the 4 points there in terms of the 4 aims of why are we doing any of this? And let me be really frank and clear up front. I don't really give 2 monkeys about 3-letter acronyms. I don't really care about governance frameworks and who sits on which board where, although we need to make sure we use public money in the right way, and we need to make sure we comply with the Nolan principles and we need to make sure we deliver really good outcomes for the population that we serve. But I think we can get lost and a bit hung up on governance and committees and structures and hierarchy and three-letter acronyms. Let's come back to the basics of what are we here to do? We're here to make sure we can improve outcomes for the population in health and care. We're here to properly tackle inequalities in outcomes, experience and access. And let's be really honest with ourselves. Those inequalities existed well before COVID. We nodded at them, we looked at them, we said, aren't they really bad? We actually did something about them with the COVID response and with the COVID vaccination response. And we need to use that as the springboard for what we do next. We are absolutely here to make sure that we deliver best use of the public pound and deliver the best productivity we can with that. But also we need to recognise the role that the NHS needs to play as a large employer, as a large purchaser in local communities to support that social and economic development and recovery from what the past couple of years have been. With a clinical background, I make no apologies for saying this, but actually it's something that we're absolutely committed to anyway. The clinical and professional leadership is a central component to that. You can't do any of those four without clinical and professional leadership. And you'll also always hear me talk about that as clinical and professional, because I include social care and social workers in that as much as I include doctors, nurses, AHPs, and everybody else from that side. On the left-hand side, two main components, an NHS Integrated Care Board and an Integrated Care Partnership. We can get into what those mean in a bit more detail as we get into a conversation. Next slide, please. Okay, having said I'm not that interested in governance, here is a governance chart for you that I'm now going to spend the next 30 minutes explaining. I'm really not. But I just wanted to just give a highlight view of how is this starting to hang together. And just for me to highlight to you, a Unitary Integrated Care Board, statutory NHS organisation, the bit that we've got automatically next to that is the Clinical Care and Professional Forum. So that just reinforces for me the importance of that. I'm not going to talk about the committees, but I think there are three main strands that any NHS Integrated Care Board's got responsibility for. A strategy strand, so our planning, our looking at the population health management, looking at the health inequalities, working through what we're going to deliver and what does that look like. A delivery strand, and I really want to get into a conversation around the role that AHPs, physios and others can play in place-based working and neighbourhood working in that delivery strand, and an assurance strand. And the assurance strand is about, if we've said what we're going to plan to do, we've focused on the delivery, are we actually doing that, and can we demonstrate the outcomes, and can we demonstrate delivery against those four aims on the first slide. So for me, forget the organogram other than three strands of strategy, delivery, assurance, and let's get into a conversation around how AHPs and clinical and professional leadership can drive those three strands. Next slide, please. And if you look at the global evidence, and I've been fortunate enough to be able to spend some time looking at this in a number of places and work with colleagues in a number of places from around the world, that there is a limited number of things that you can actually do that the evidence demonstrates gets us into population health management, gets us into delivering those outcomes and tackling health inequalities. I was put off then by Lorraine with a camera zooming in on me that I could see that it was taking a photo. So the evidence would say there's 8 things and 8 strategies. And if you look at those 8 strategies, then I think from an AHP's perspective, you can look at each and every one of those and say, I can see where I can add value in that space. And I think that's part of us thinking about, not about a governance chart, not about hierarchy, but actually how do we make a difference for the individual person or for the population through one of those 8 strategies. And each of those, I think we can play out in terms of how do we work in a system, how do we work with partners, how do we work in our own individual practice, how do we work in our team, how do we work with residents and patients at an individual level. So, whether that be the citizen-centred approach, whether that be investment and development in primary and community care, whether that be really thinking about what do we mean by a whole systems approach, If we talk about tackling unwarranted clinical variation and we look at a musculoskeletal pathway, or we look at a long-term conditions pathway, the logical approach that AHPs bring in terms of lean management and in terms of pathway mapping and the patient journey and the resident journey. If we look at then how we can use the digital technologies to really drive the way we change the way we deliver care, the innovation and the new ideas about how we can deliver that care, and then the partnerships that we work in and the scale that we can work at to really drive that agenda. And I'm sure people want to come back to one of those 8 at different points. Next slide, please. Okay, and the final slide from me before I hand over to Claire, who's said she's going to deal with all the really difficult issues throughout the rest of this evening. Look, this for me, I could ask the question, what do we mean by integration? And there's 55 people on this call. I'm probably going to get about 80 answers if I ask what do I mean by integration. For me, let's break it down into something really simple. It's about giving people the support they need, and it's about us joining up care across boundaries. It's about tackling mental health and physical health, so looking at an individual as an individual, not as a condition. And it's about really coordinating care so that we don't have gaps, we don't have grey areas, we don't have you know what, I work in the acute trust, I've seen what I need to do, I'm now writing a referral to pass you across to the community or to somewhere else, or vice versa. Actually, we've got responsibility for the community that we work in. It's about working as close to the individual and to the community as we can, and it's about building an approach towards engagement that gets us into an ability to have a conversation with the population we serve, to really start to think about how we shape sustainable health and care services going forwards. So I'm going to pause there, Phil. Hand over to Claire, who will take us on to the next piece, but look forward to coming back into the conversation after.
Really excellent presentation, thank you. So we've now got Clare Pheasant going to present to us. So please do keep posting your questions.
Phil, I'm sorry, I can't hear you.
Not hear me at all? No? Can you hear me now?
You're just a bit quiet. You're just a bit quiet, Phil. We can faintly hear.
Sorry,
oh, that's better. There you go.
I've unmuted and muted again. So thanks so much for that, Simon. Really excellent presentation. So keep posting your questions in the chat box, and I know that Lorraine is keeping an eye on that as well. So thanks very much, Lorraine. And I'd like to introduce Clare Pheasant.
Hi everyone, thanks for inviting me to come and talk tonight. I'm going in true style as well. I've got my Twitter handle on there. Mine are nowhere near as many as you guys, but it is on there, and sometimes I post some interesting stuff, sometimes I don't. Again, I'll talk a little bit later on about how I got to the roles that I am currently in, but I'm currently in a position as Chief AHP for Coventry and Warwickshire ICS part-time, and also work as Associate Director of AHPs at UHCW Hospital based in Coventry and Warwickshire. Next slide, please. Thank you. So again, this is quite a brief overview, and try not to overcomplicate it. I think we're all really keen to have some really good discussions with people later on, but this is kind of a bit more of a detailed look into how maybe systems are going to be set up. And really this is just to give you an idea of some of the terminology. Whilst we hate acronyms that are utilised, whether we like it or not, they are in some of the forums that we sit in, and so it's useful to have a basic understanding of what people are talking about and relating conversations to. So I'm going to start in the bottom corner around PCNs and neighbourhood working, because that's where some of the really good and useful transformation is going to be occurring that I think we've maybe been blinded to it in the past, and this is a real expansion of primary care teams and getting care right out into neighbourhoods. And from an AHP perspective, that's things like the expansion of additional roles in primary care, that's things like AHPs going into care homes and giving care actually where it's required rather than bringing patients into hospital. It's things like our urgent care response teams who are kind of hopefully diverting people from our urgent pathways in hospitals. So PCNs are made up of clusters of GP practices, and those GP practices will work together to deliver care to those communities within their kind of patch in the right way using data. to support the decision making. The next layer up is place, and again, it feels like a funny thing to say. We talk about we're going to the place meeting and you want to know where this place is and what's going on. So place is a group of primary care networks, but also local authorities, NHS trusts, health watches, etc., working together to deliver care in a really in a shared way, trying to get rid of those organisational boundaries. This is a real move from competitive nature of delivering care to real collaboration. And again, using data related to the health of those individuals within that kind of community. In the area that I work, in Coventry and Warwickshire, we've got very different health needs across our place. We have 4 places, and each of the priorities in those 4 places are quite different based on the health needs of those populations. So it's starting to take account of how we deliver the right care. You know, we say deliver right care in the right place at the right time, but it's really being driven by that population health data that we can access. And then moving on to what the whole system does, and that really is, as Simon's already alluded to, that's about looking at some of the bigger things that we can work on together. It's making sure that there's consistent standards. It's making sure that the workforce planning is done in a collaborative way. I certainly know that when we recruit, we quite often recruit from local organisations that are actually now within a system and should be collaborating and working together. So it's how we do all those kind of things joined up without really reshuffling the card deck is what we do. Right, we need to work together to build on what that workforce needs to look like to help the whole system, and how we can start recruiting people along pathways and trying to forget about those organisational boundaries. And it will really start to push some of that unwarranted variation and the differences in access to some of our services across the system. Next slide, please. So again, another picture, as we've said, we don't like to talk about infrastructure, but really it's there whether we like it or not. And this is really just a little bit more detail around, from an AHP perspective, how as a group of professionals we've been trying to work and integrate with our integrated care systems as they develop. And I hope everyone on the call is aware of AHP councils and AHP faculties. So I'll give some detail around that now. But again, if it's something that you're not familiar with and want to ask more questions, please do at the end. This is a basic model of what happens in my system in Coventry and Warwickshire. So we have had an AHP council for a number of years, and that hasn't been necessarily chief AHPs sitting at that council, because those roles didn't exist 2 or 3 years ago, but it was AHPs that really had a vision and a desire to try and do things differently and work together to start trying to transform the services that we could influence without having to fight the red tape. And so that AHP council meets on a monthly basis, and we have representation in our council from NHS providers. We have had commissioning in there. Clearly that's altering at the moment, local authority, primary care, and our HEI colleagues. And that focuses on some of those big strategic or transformational opportunities that we can look at together, and trying to really understand what the workforce looks like, what it needs to look like moving forwards, and starting to build a collegiate plan together around that. More recently, as I know a number of you will have been involved in, our AHP faculties have been set up. And these are the workforce powerhouse, as we like to say, and this is where a lot of the doing goes on around that workforce. I mean, in our particular ICS, we've been really looking at placement expansion, as I know all of you have, and physio is still a real challenge for us to offer the number of placements that we require to build on our future workforce. But we've also been looking at things like return to practice and international recruitment, not specifically within physio, but absolutely around diagnostic radiography, where we've got some real challenges that do impact on the pathways that us as physios work on. Preceptorship's been another key area about how we retain those newly qualified staff. And that's been a particular focus the last couple of years, because it's been extremely challenging for everyone on the ground, no matter which segment of health or care that you work in. And those preceptorship programmes add real value in keeping those staff safe, healthy, fit and well to move them on through their career within our organisations. And then we're also, I can't not say it with Lorraine being on here, but support workers is a huge focus for us, and how, we'll maybe hear later about how people can move from those roles into other positions and how that pathway can look. But we've got a huge cohort of support workers in our system who of varying levels, who some of which have got a real appetite to develop into registered roles and beyond. Some don't, but it's about giving them the right skills and capabilities so that we keep them and retain them, because actually they have huge amounts to offer and are actually going to be the solution for a lot of our challenging work going forwards. And then this is I suppose what I want to say here is, this isn't the people involved in all this work, these task and finish groups, this work that's going on, this isn't because people are in a particular position to sit at those meetings. This is people who have a desire across our system to engage and get kind of do stuff. No one's being paid specifically to do these roles, but we all recognise that we've got a real opportunity to work together to deliver some of the transformation that's required. And then kind of around there, what is happening, what has been the change with the development of the ICSs is clearly a chief AHP in a system has not been a thing until very recently. And so that is new. And I am in a position to sit at our ICS People Board and our newly formed ICS Clinical Executive. And that Clinical Executive is made of senior leaders from all the professional and care groups within our system. So this isn't about always being at the table and shouting, but actually to have that door that we haven't had as AHPs in a lot of areas to that kind of senior level is helping and supporting us in driving some of those big risks that we've had for a long time in taking those forward. Next slide, please. When I talked to Phil about what I should chat about here, this was just to give you an idea of the kinds of things in my ICS role, what I am currently, this is kind of my work plan at the moment, and it is only a couple of days a week, and the list could be never ending because there's so much we could do, which is why it's really important that everyone who can and is willing gets involved. The biggest thing for me is the AHP workforce plan. It's really challenging to actually even understand what AHPs we have in our system. Where do they sit? Who looks after them? What do they own? Linked with some of the work we've been doing with HEE, I will in the next 2 weeks have an establishment for the whole of our Coventry and Warwickshire system, including primary care and local authority, something we've never had before. We didn't know how many people we had. And until we know what we've got, we don't know what the transformation potential really and truly is. So that's kind of the big focus for me at the minute. And that isn't me doing the work, that's linking with workforce colleagues, that's linking with AHP leads across our system to pull that piece together. And what that will allow us to do is look for where we can start doing things like shared rotations and recruiting along pathways rather than fully looking at organisations. One of the other things I'm involved in is elective recovery, and this is physio focused predominantly, but we've been using girth data, and we have unwarranted variation within our system around some of our orthopaedic activity. So I'm chairing a meeting system-wide that's pulling all the therapists who are involved on the ground delivering care to these patients, but also the orthopaedic consultants and the operational leads across our acute trusts to look at how we shift and move to learning from the best practice that is going on in our system and making sure that we spread that across all the organisations. AHP roles in primary care, again, a hot topic in physio circles at the moment. We do have a workforce plan for our primary care teams for the next 2 years, so we know exactly what's on their list, so we can proactively start training and developing staff to step into those roles. And I know in some systems and areas that's been a real challenge because there is this pull of staff out from rehab areas into these additional roles. And we're trying, where possible, to do this in a managed and controlled way across our system with support from our primary care partners, which has been really positive. Long COVID, again, physio and OT predominantly. We set up our long COVID rehabilitation services in our system in a place-based. So we had 4 different pathways for long COVID patients in Coventry and Warwickshire. We know that the funding is not going to carry on in the same way that it is currently longer term. And we need to look at a sustainable model across the system where everyone's getting equitable access. And we're also doing a piece of work linked to population health management around, actually, we know where the incidences of COVID were high. Are those people accessing our long COVID services? Or is it the people that we know who always access our services really well, accessing these services as well? So it's kind of marrying that data set up. And I've got on there something around population health management. I think this, in some pockets of AHPs, this is a new way of looking at things in a more formalised and systematic way. So I've put on the next slide, and I won't go into any detail because I'm not an expert and I'm on this journey as well. Next slide, please, is the core 20+5. My ask here is that you just go away and look at it. I know that if I'm going to pull a case together around transformation, it's not going to go anywhere if I've not referenced what is in this document. And I haven't put it on the slide pack, but I will send it to you, Phil and Mindy, afterwards, is some links to where you can find this information. Also, there's some free e-learning training around core 20+5 as well, that again, if you want to have a look and understand more, I urge you to go and access that and see. Next slide, please. So last thing for me before I hand over to Seema is how you can get involved. Go find out what's going on in your trust and your ICS. What are those tricky issues that need solving, and have you got ideas? Bring them forward, understand what your system priorities are. If you don't know, your service leads will know, or senior team, operational teams within your organisation. Everybody's got something to offer. Think about the pathways that you're delivering on and how you can impact on health inequalities in your particular area. And what solutions might you come up with? And you know, one of the things we've been talking about at some of our organisations is, should we be looking at our waiting list purely based on who's been waiting the longest, gets seen first? Should we be accounting for some of the socio-economic demographic information as well? Is that person who's on the waiting list the only carer of a family, and if they don't get treatment, they're going to be going to a food bank? Those kind of things. How do we make that kind of part of our kind of bread and butter stuff? Be open to trying something new, and dare I say it, don't use the term we've tried it before, because we have tried some of this stuff before, but we're in a different place, and I think it's a really exciting place. And for those of us who've been in work longer than we'll admit here, is I think this is one of the biggest shifts that I've had in my working career, and I'm sure probably will have for the next, the rest of my working career. There's a real opportunity to do stuff differently if we can embrace the big changes that are happening. And the last thing is to make sure you sign up for the Midlands AHP network updates and join the NHS Futures website and the AHP pages on there, because there's a vast amount of information on there that is really useful, and you can search for things that are relevant to what you're delivering at the moment. I shall hand over to Seema.
I think the biggest difference between this episode and the previous episode is the fact that we're actually in it and things are actually happening now. Last time round, we were talking about things that were going to happen and plans for the future. And what we're hearing tonight is opportunities that are actually here in the present, here and now. And I think that that's the tone of today, that this is real, this is happening. So now I'd like to introduce Seema. Seema, if you'd like to introduce yourself, and the stage is yours. Thank you very much.
Thank you very much. Apologies. Can you all hear me? Okay. Yes, thank you. So my role, I'm a director of therapies at Birmingham Community Healthcare, but also have been appointed recently in the interim ICS AHP lead within BSOL. So I sit in the clinical and care professional group. So next slide, please. My Twitter handle is there, and please feel free to contact me anytime, through email or using Twitter. I'll try to be as responsive as I can. Thank you. So I thought Simon covered beautifully of the whole infrastructure, and Clare has covered the areas which, how we have seen the opportunities within the ICS and what we have been doing. What I would like to share is slightly a personal slant within that is, particularly when the enormity of the post-pandemic challenge has meant that there was no choice but for all of us to come together as chief AHPs across the provider organizations and social care together. And fortuitously, somehow we had to enable us to move forwards, we had to work differently away from the traditional models that were there. And we were able to build new and improved services completely in a different way, supporting each other across organizations. I think for a lot of you would have gone through this as well too. You had a lot of redeployments, and throughout that, what came across was a system approach. Since the beginning, it was inspiring to see how all the professionals, all the clinicians and the communities also got engaged with us in working together across the organizations. And there have been no barriers, I must say, the barriers that were not brought down. So there will be, as you can see, challenges which we will have to come across, and there's some of them I've listed here, but through system and collaborative working and the willingness to work together to resolve that, it has made us, but particularly AHPs, and a lot of them were physios, OT, speech and language therapists, it has made our voice much more clearer and I would say impact seen across the system. So one of the issues we have currently is maximizing where we are able to make a difference is maximizing capacity, flow and discharge, and then designing the services that will keep our citizens, communities closer to their home. And all these services working closely with ambulance services, with primary care. As physios, I think we are well placed to drive these services and also lead these services through roles such as ACPs and FCPs. How we access the funding for enabling these developments, that's what's come through a bit more apparent and clearer. I think for us, throughout again pandemic, it was clear the impact of health inequalities and the access. But as physios, somehow we are always outcome focused. So by empowering our communities and co-producing the services with the service users, utilizing our innovative approach, we have been able to support the self-management virtual clinics where appropriate and virtual placements, those kind of things, to enable our services to go as much as possible and as close to keep people as much as possible at home or closer to home. We are definitely a step forward in tackling these inequalities, particularly considering the digital poverty, cultural issues that all came across. The other challenge we do have is the adopting a continuous, the other, not challenge, I would say, the other opportunity we have is to adopt the innate QI approaches we use in understanding the productivity through our job plans, which we have all recently, most of us have gone ahead forwards with our job plans, understanding our capacity and the variations that exist, enabling us to articulate it effectively as to what we think the staffing levels should be. So that has been, I would say, a big opportunity for us. And then obviously, we've got workforce, and all these have been possible because of our collaborations, our AHP faculty and council, and access to what we have been doing and being able to articulate to people's board, quality group, depending on which system we are in, we are able to have different systems are at different levels. So what access we have been able to utilize and maximize our opportunities to present our case strongly, I would say. So one of the the interesting thing that when me, Claire, and Simon met up we were talking about being at the leadership tables and the senior roles, and how do we access, and are they really important? I think every opportunity, every individual at every level has got is a leader in themselves, and has got, with their passion and drive, will be able to drive and bring it to the tables where we will be able to hear and make our case stronger. So one of the involvement where I have is the clinical ICS clinical care and clinical and care professional leadership. Next slide, please. Next slide, please. Thank you. So these are the ICS and the ICS design framework was published in June, and that summarized a key requirement for the design and development of ICS, included very heavily and has been very clear in clinical what it should look like, and the implementation guidance that was published later on in September detailed our core expectations and the principles that have been. So the previous slide mentions about the 5 principles where it worked over. The figure that you are seeing right now, it's a draft, our draft model that has been developed. So most of these principles are covered we can see that the opportunities, they are recognizing that the clinical groups hold expert knowledge and care around the delivery and ownership, which is fundamental to our ICSs. Our model on this slide shows how different layers of the system can interact and communicate, so that we are able to be at the we are able to inform the decision making and the flows. It just shows you the flows that are there from every level. These are based around care programs. So in our system, we've got the opportunity to influence at the wider clinical care summit, which we are hoping that we'll have that biannually. And feeding into it is our AHP council, AHP faculty, and all other clinical groups that go into there. That will again feed into system quality group and the clinical and care professional leaders group, which is from the ICB. Again, as earlier on, if you saw what was presented by Simon, and also what was presented by Claire, that looked slightly different, but in the system structure. But we have got opportunity to be doing this at place level, at the care program level, and at the different clinical leadership level, which will then inform the people committee and also the quality committee, and that again feeds into the ICS overall ICS integrated care board. So any questions you have? I think the priorities will probably depend on which system you are, but this is an example, and it is continually developing and being informed by how the ICS is developing. So if I go into the next slide, please. So one of the things that I wanted to mention was the most of the influence. So when we started off, we held 4 workshops, which were across multi-professional involvement. The first workshop kind of had initial discussion in understanding, reviewing the philosophy of care and what the next steps should be. That focused. Then further on the second workshop, we were focusing on clinical care and leadership and how that should look like. And the third workshop focused around the system collaboration and thinking, which again, 4th workshop was around what should be, is planned around system quality assurance. The philosophy of care eventually evolved that it needs to be a personal-centered care that we need to be developing, which needs to be personalized and seamless. We have something called an inception framework, which features across through the CPL throughout, demonstrating what importance it has for clinical leadership and how important it is to engage all the wider professional clinical leaders in each of the pillar and the principle. So we've been using, in addition to that, we've been using support from NHS Elect and our ICS community teams to produce a series of case studies, stories, which share the good practice, and for us to actually engage and enable more engagement from professionals within the system. And that's an opportunity for us to take on, really. Sometimes we might feel there's, we all have full-time days job, and how do we do that? But I think, as Claire mentioned earlier on, a lot of them who are working within faculties, who are supporting the councils, are doing it because of their passion, and this is an opportunity. Even before our the development of ICS and ICBs, I think within BSOL, we already had people coming together and working across organizations. One of the examples was something called early intervention community teams that were developed, and then the long COVID program that we had, the MSK transformation program. All these already existed before the start of the ICS and ICB and moving over from the CCGs. But this were the system-wide projects which are across organizations, bringing health, social care, third sector organizations together. So we are planning to use these these cases as sharing best practice examples. So one of the principles within that mentions about the principle 4, which is time to lead, and leadership program, which is already established within our system, again but we will be looking at ensuring that the CPL is developed by exploring these experiences with the senior leaders to look at how we could, what further support is needed, and by talking to them and who already work within the systems, what could we do collectively? That's something that, and which is not done as an individual organization. That's something we are hoping, and this is again in line with one of the principles that I just mentioned within that. So now coming on my reflections, I think because it's continuously developing, refining, embedding the models, approaches are so different within the systems, how much time and where you are placed as a system leader, and what understanding there is about your professions within the senior leaders varies, and what opportunities you may have also varies. But my thinking is that we have to maximize that opportunity and always make sure that we are able to articulate what value we add, no matter which table we are at. So I'm sure, let nothing stop us is the way I have been going about. But within that, most important is looking after yourself, each other, and stay connected. I think throughout this process, it has been tremendously useful, helpful to have the colleagues, my fellow AHPs, chief AHPs who've been working within the systems, and my, working with the NHSIE, with the HEE colleagues, with system colleagues. Working together is something which was the key, and looking after each other. Again, Claire already mentioned the briefing sessions. Keep up to date. Even sometimes you're listening to, like you would listen to the podcast, just listen to these as you're going away from home or coming, look at the, attending and listening to the webinars, best practice examples, because we never know what you might think about suddenly, and what you might feel would be the best approach that is being already embedded in another system. Maybe that is something that would work for you. So attend as many as possible professional networks, forums, engage if possible, drive the work streams within the faculties and the councils, engage with the communities, because every community is different, every area is different. And last but not least, think about opting for portfolio careers. When it broadens our understanding, look out for roles within the ICS, HEE, and HSI. There have been so many fellowship roles which have come through. I think whoever attends the chief AHP meetings, or if you come across a role that you think is interesting in another system, try and send it across to your fellow. Have a distribution list, send it across to your fellows, and that might interest them. Or if you see an opportunity, discuss it, challenge it also. If it is not open to AHPs, if it's not open to physios, if you feel that that is the right opportunity, that we are represented there, or we are we should have equal opportunity to apply for the rules, please, I think we should be able to bring that, because they might not necessarily know it. So do consider portfolio careers and don't hesitate to try out new opportunities. With that, I'd say thank you.
So what we've had there is 3 very different presentations focusing on different angles, and I'd like to thank the presenters for working together to collaborate in approaching this from 3 different angles, and it's given us some real food for thought. So within the chat, there are some questions that have been posted, and I know Lorraine has been keeping an eye out for those. So Lorraine, are there some questions in the chat other than the ones that I've posted? Because I did get a bit carried away.
No, that's fine. I'll just bring them up now. So I'll start at the beginning. I've got quite a few. First question to the panel is, what is the relevance of being a foundation trust in the context of an ICS model?
So that's, I think, Phil, that was your question, wasn't it? And if I pick that up, Clare, Seema, if that's okay, and then you can come in if you've got views. Look, I think there's a couple of bits around a foundation trust. Let's be honest, the reforms, to some extent, clip the freedoms and clip the wings of a foundation trust because of how they control use of capital money, and they move that to a system level rather than individual organisations. There's a flip side to that, though, given the work that foundation trust, when done well, did with developing governors, developing links with communities, and actually we should be maximising and using that route to build the engagement and build the conversation of the work that we need to do and get the views coming back through. So if we use the benefits of the FT process in terms of the governors and that wider community connection and link where foundation trusts have done that well, then I think we're in a much better place to use that. But I think some of the other aspects around capital and use of finance and use of resource, I think some of that's been restricted or moved into a much broader partner system approach of how do we use it.
I think that's a good thing.
Do I think that's a good thing?
Yes. No, I happen to think it's a good thing.
Yeah, I agree.
I've got another question. Please, can Clare talk some more about place and what place-based healthcare means to clinicians and service users?
Yeah, I think again, everyone chip in if they need to. I think for me, this is absolutely that approach of we need to take care out to people rather than people come to us in its basic sense. And I think we've got real opportunity to explore that. And you know, some of I work in an acute trust, but have worked in community and primary care myself. I think it's about using the expertise that we've got along pathways and taking that out where we can, when it's efficient and appropriate. There's absolutely stuff that needs to be delivered in a hospital. We're not going to close hospitals down. I suppose you could argue if we worked really well as an ICS, you should be able to start shutting beds and things down in a hospital. I'm sure we're never going to get there, but for me, the basis is taking that care and that expertise out into communities and into people's homes or local kind of health providers in its simplest form. And that for us as HPs, like I say, is those additional roles that are now within the GP contracts. That's paramedics, physios, OTs, dietitians, as well as pharmacists and social care prescribers, etc. But it's also kind of looking at those going into care homes and those urgent response teams to stop people coming into secondary care when it's really not the best place for them to be. I hope that answers the question.
Thanks for that. We've got a question from Rachel for Seema and Clare. Now you're employed by your ICS, albeit part-time, has this made an impact on your ability to deliver council and faculty priorities?
Hi, Rachel. Go on, Seema, you go.
Okay, thank you. You go next. So in terms of part-time, the roles are, as you say, part-time. So I think even between us, Claire and my roles are different in terms of part-time. So I've been predominantly working along within the Clare and professional leadership group, and Claire has been within that, and she's been doing more a broader role in terms of taking on operational side of it as well. So in terms of my counsel and ability, I would say no, because one of the principles of the 5 principles I mentioned, the 5th principle is, workforce. It's related to it, and the best place to deliver that is through AHP council and faculty. So far it hasn't, but if we do feel that, when the work very clearly, and I think once in my system I can talk about, we've only had the exec roles appointed and started this month. So once they develop their teams and have got portfolios for them, working on their portfolios, I think clearly, I'm sure it will be recognized that there is a need for multidisciplinary input at every level. And so therefore it might change depending on what roles we will be taking. But I think there is a brilliant opportunity here, so that it's not just one person or 2 individuals, but as Clay talked about, at every level when they are talking about. So when we are at every level, we bring that together back into faculty and council. That's how I would see that as. Over to you, Claire.
Yeah, I think again, in its briefest form, I'm happy to pick these conversations up offline with people if they want to. For me, yes, I would not have the level of workforce plan that I have now almost got had I not had the allocated time to do that from a system perspective. Done it within my own organisation, but not at a system-wide view. And I think that's been the difference. And let's not forget, every organisation has had a ability to appoint someone to look at workforce for the last 6 months, and we all know that without that infrastructure, again, I've done a lot, but I've used that HE resource in all our organisations to help me to deliver it, and I think that's the case all of us have to make at the moment. Is actually we're now going to have lots of workforce plans, and we're going to understand the risk, and we're going to see what the transformational potential is, but we need to try and carve out that capacity now to deliver it. And that is the challenge.
Thanks for that. We've got a question for Simon from Libs. How do you plan to ensure the voice of AHP is heard, valued and integrated into your ICS?
So, I think that question is relevant to whether that be AHPs, whether it be medics, whether it be nursing. Actually, the most important bit is residents and members of the community. How do we make sure their voices are heard and valued and integrated into the work that we do? I think it's about every level, and both Claire and Seema have articulated that really well. I think in terms of where are we having the impact. The other bit is the culture that we set in terms of how do we want to work, which is being willing to listen and actively listening and getting out there to do the visits and do the walk round. So next week I'm going to Robert Jones and Agnes Hunt, and part of that will be I want to hear what it's like working in that trust, and where the difference is. The week after I'm going and doing a shift in the community. So there's something about doing that at every level, and I expect my leadership team to have a similar approach of getting out there. But then we need to make sure the structures deliver that level of engagement where it adds value and makes a difference. I don't just want talking shops. I want the conversation where that engagement and that conversation makes a difference to the care that we deliver to the residents we've got responsibility for. Some of that will happen in PCNs, some of that will happen at place, some of that will happen in other structures, some of that will happen at the clinical and professional forum. And I want AHPs, and the same as I want nurses and doctors, engaged at that at every level.
Brilliant. Question from Phil. As someone involved with working on MSK transformation, part of the big ticket items is a forming system. I recognise the challenge of leading innovation and managing the business as usual aspect of the day job. What advice can the panel give in relation to managing strategic and doing workloads, given all you have competing roles and wear multiple hats?
think it's probably the same for everyone, isn't it? If we asked everyone at the moment, it feels like there's lots of competing demands. I'm also doing the MSK transformation, Phil, as I know we've talked about in the past in our system, or some of the work around that. And I think for me, there's winning hearts and minds and getting people involved. So if I pick up what Simon's just said, we start a lot of our pieces of work with the patient stories. So this is why we need to do something, and get people on board then to work together to deliver it. So why are we all here? What are we all here to do? And I think there's a real cross. We talk about system, but system isn't a thing. We're all part of the system. It is us. There isn't a whole group of people out there who are, Suzanne Rastrick says this about AHPs, isn't there isn't a group of people who are going to do this. I think it is that hearts and minds piece. And Phil, sometimes I've had to make the decision not to go down a route that I particularly want, because it's just really hard work and I'm not getting the traction. And sometimes you have to choose a path of least resistance to get people on board, to then kind of actually people, you talk about that tipping point, don't you? And there's always a group that will eventually come on. So I think it isn't easy. None of this is easy. Joint recruitment's been really hard in our system, but we've had a real positive and we've really gone at it with long COVID. We have recruited jointly as organisations to that pathway. It's been really painful and it shouldn't be, but actually it's really positive, because we have now got some clinicians working between organisations, supporting patients along a pathway right the way from assessment through to rehab and then on into their kind of homes. So I think it's choosing a path of least resistance, trying to kind of really get that vision from the start. And sometimes you do have to change tack, just because if you want to make a difference some way, you almost need to at the minute just kind of work that through.
Brilliant. We've got a question from Clare. If you had to explain ICS in one sentence to someone who does not work in healthcare, what would that sentence be? Thank you all. That's to the panel.
I think Claire's answered that in the chat.
Oh, has she? Oh, there's more questions. I apologise.
No, it's okay. Right, so Claire's put her answer to that in the chat.
Brilliant. I think we've got one from Amy. As a Black Country ICS, we are planning on including a module in our system to wide preceptorship programme for newly qualified AHPs to share information about infrastructure, and we're discussing tonight the role of AHPs have within these to increase understanding and awareness. But do the panel have any suggestions on how to share this with all the AHPs throughout the organisations? How have you increased knowledge and understanding throughout your organisations?
So if I make a start, because I probably want to pick that up with Gordon's question below as well and take both together, which is around ICS has been a complex area and challenging to comprehend. How do we make a difference at the coalface? So look, I'll make a start, and then Claire and Seema, I'm sure we'll have things to add. So Gordon first. Actually that probably says I've not delivered my presentation very well, because I think we overcomplicate unnecessarily, and I don't think an ICS is complicated, because when we talk about what we want to deliver in terms of care, and what that means to residents and what that means to patients, then I think that's really simple about how better, and every clinician, every physio assistant, every support worker will see and have experienced times where they've looked at an episode of care and thought, we could have been more joined up there, we could have done that better, we could have got a better outcome for that individual or for that family. And working in an integrated way is simply taking those opportunities and doing that consistently better every time we do it. I think the question that links to Amy's point above in terms of, I think, look, really positive. I know Mark Axel well, so no surprise that he's doing some great stuff in terms of the preceptorship programme, and I want to hear about what that is and share and steal with pride in terms of some of that. We've just got to keep talking about what this means for residents and what this means for patients, and the role that clinicians and professionals can play in this, without us getting hung up on the governance, the structure, the meetings, our training. It comes back to Phil's question. Our training, I think, puts AHPs in a brilliant position to be able to take leadership roles in some of this, because they see the difference they can make, they can join the dots. The training makes you think in a logical, reasoned way, and you apply that then to working with partners and working with groups. And I just think, you know, I want that to be really pushing at the forefront of the transformation work that we deliver. So that would be my starter on that one.
Brilliant.
Clare, Seema?
I agree
Yes.
completely. I don't think we need to add anything. I think this is AHPs. We're trained to work across pathways. We start our training across lots of organisations, so we have that insight that maybe other people don't have routinely. So it's really helpful.
Thank you. And I think I agree with both Simon and Claire. I think somebody said to me, when you go down, so how do you know that that you've made a difference? And if you just walk up to your you know, cleaner, for example, in a ward or somewhere, when they're able to say what they are going to do, what they do, how that makes a difference to the patient that they're seeing, that's when we know that we've done the job. So I hope that you know, coming from an AHP perspective now as a physio also, I think no matter whether it's a band 5 or somebody who's doing a preceptorship or a physio assistant for that matter, or anybody in the ICS, if we go up to them and ask them what do they do and how do they make a difference, I think if they've answered it, that's it. If they're able to say, I think that gives us.
And so just to really add very quickly to that, because I think that's also a really important point, Seema, I thought when I'd heard that previously, I thought, well, it's great to answer like that, isn't it? But what does it really mean? But I was fortunate to have some time working in Sweden, in Jönköping, and they made a big thing about their saying each member of staff has 2 responsibilities: to do their day job, but also to find a way to improve things for the residents or the patients. And I went off-piste and did the walk around and did exactly what you'd said. And they absolutely live and breathe that. They'd set a culture of, you know, we've got 2 jobs. I do my day job, and then I've got to find a way to improve things. And we've got to get that culture built in not in a top-down drive that, but actually because we can do better for the residents and for the patients that we look after.
Yeah, thank you, Simon. Another question: how do we balance the welfare needs of staff post-pandemic, as this is a significant part of workforce planning in the short to medium term, as we look to try and increase elective capacity?
I don't want to dominate Clare and Seema, but I've got
Go on then, go for it, Simon. I can add in after.
No, you go first. I'll follow.
I was going to say, I think it's forefront of everyone's mind at the minute around, you know, health and well-being of staff. I think, yes, it forms a kind of a golden thread throughout all the workforce planning, and there are no golden bullets. But also, I think some of this links to this isn't the workforce planning piece isn't about getting more. A lot of what we're doing is about using what we've got in a different way. And I know that sounds very easy to sit here and say that, but you know, there isn't a bottomless pit of money. This ICS doesn't come with a new envelope of funding. It's the funding we've always had. So there is something for me about workforce planning. I've had a conversation with my chief nursing officer today saying I've got this brilliant AHP plan, but it's AHPs doing what AHPs have always done, because I need to know what the nursing kind of workforce looks like and what the medical nursing workforce looks like and what the pharmacy workforce looks like. And then actually we need to pick some pathways and go, right, we're going to deliver something in a completely different way. I'm all for, and people will know my organisation because I'm like a broken record, I wish we didn't have professional registrations on job descriptions. I wish we just had a set of skills that were required, because then we'll really start to transform some of the services that we need to transform. So health and well-being, I think, is forefront of everything that we're doing. I think we need to get better at flexible working. You know, at CSP conference this year, we talked about actually as physios, we're not great at supporting people with disabilities, for example. You know, we need to get better at all of that to keep people kind of in work and wanting to be in work. But I think the workforce planning piece for me is actually, we can all come up with a plan of our establishments and gaps and what we need more of, but we need to start doing that transformation piece.
So look, really comprehensive answer, Claire. I started as a physio assistant, and so, you know, I've done physio assistant and then went and studied, qualified and worked through. So, you know, I've seen lots of different levels. The workforce challenge is our biggest challenge. Let's just, if somebody says to me, Simon, what do you worry about the most? I don't worry about the money. I don't worry about the plan submission dates. I worry about our workforce, the workforce that we've got now, the gaps that we've got, the pressure that we're putting on people, the fact we are asking them to go that extra mile again and again and again, and often asking to go that extra mile in an area that they're unfamiliar with or uncomfortable with. So, that's my biggest concern and biggest worry. I think I agree with Claire's point of we've got to start thinking differently about workforce. So I want a workforce that we can develop and grow in our area, where we build on what we've got. So if I go back to one of those 4 principles, social and economic development. Well, if we can bring through people from local colleges, and we've just developed a healthcare support worker apprenticeship pathway and a healthcare support worker route from college through into local services, where we can bring people through into some form of rotational healthcare support worker that goes between social care, domiciliary care, that goes into the acute trust, that goes into community, that goes into general practice, that gives people a range of experience. Then we find routes to make sure that we can, those that want to do a professional qualification, whether that be physio, OT, dietetic, pharmacy, nursing, actually you've got a route to be able to do that from the local system into local organisations. The chances are then those individuals will have settled in the area, will have a family in the area, will live in the area, and I'm much more likely to keep them then working in that area once they qualify and get that professional registration that Claire's talked about. So that's going to take a number of years to get to that point. That's not a quick solution. But if we don't start planning for that now, we'll keep saying it's going to take a number of years to get to that point. I'm challenging our apprenticeship team to say, how many apprenticeships are we taking after the looked after children's list? Where are we getting into the real health and equalities piece of looking at where we're recruiting our workforce from our local community? We've not got it solved. I'm not saying it's solved. And I recognise I'm asking my workforce team some really difficult, challenging questions. But I think that's part of my role, is to trigger that, to think differently and to get into some of that space.
Thank you, Simon. I just want to add on to those 2 bits. I think very key mentioning. I'm glad you are doing that within your system, and I think different systems have got different opportunities. So something similar we've got called Fairer Futures Fund. So I don't know if that is across each of the systems, but tapping into those and ensuring that happens. So there isn't going to be a small solution. And I think I see it as, we have got to have different investments in different things. So, everybody's very good at, you've got high waiting lists. So therefore, let's bring in some agency, bring in some, subcontractor to somebody, making, everybody is at a point where they're looking at how do I deal with it now and, then and now. But I think they both go hand in hand. While we have to deal with situation now, we have to also invest in growth. We have to invest. So apprenticeships are a great route. But and also to tackle inequalities, I think you have to go into the community and understand what they need. So one of the events that we did here in Birmingham, it was going into Somali community. So why are they so disengaged with the healthcare system? Why are they? And how do you then engage? That's because we haven't actually gone out and shared our experiences, show what we could do. And how do you bring the representative population then? If we invested, quite a lot of, one kind of a group of people, and the group that you're treating are something different. So how do you then build, especially if I was to talk about speech and language therapy, and I'm using that because it's not physio, so I'm doing that as an example. And if you have to use always interpreters to attend, then how are you going to get the outcome that you want to? So what is there, in terms of economy there? So I think it's really key. Apprenticeships are a key. I know it's a lot of investment and it's a lot of persuasion, but if you did that as a collectively, as a system, I think there is a greater opportunity, and utilizing the existing. So initial investment will bring long-term gains. So both of these have to go hand in hand.
Yeah. So Lorraine, to colleagues that's still on the call, one of my frustrations is having come through I think Seema, that's really helpful. Having come through the physio route, career route, one of my frustrations, the system that I worked in, I've done a number of levels there. I was a senior 2 physio and a senior 1 physio. That ages me to some colleagues on the call, having been an assistant first. the acute trust team that I was part of and the community trust team was almost never the twain shall meet. And it was just we'd hand off in between. I come back some 15, 20 years later, not to the Shropshire, Telford and Wrekin system, a different system, and still it's almost never the twain shall meet. So where across the Midlands have you got that sorted? Where have you really brought together acute and community and specialist teams so that you've got that seamless workforce that's working across? Because otherwise you've got almost artificial gaps in different teams looking after the same population, looking after the same residents. So I'd be really keen to hear where people have got that sorted, because I want to come and have those conversations and learn from that.
I don't know if I could say sorted, but I think we are in the journey and the pathway. Okay. So
yes.
It started with, I think, as I mentioned earlier on, as good practice for COVID. I think it was really good to see how the pandemic brought us all together, whether it's the private GPs who have got special interest to work with us, or whether it's the ITU specialist who was coming together. Predominantly, physios drive and OTs drive this. So the AHPs leading this and working with these, bringing from primary care, secondary care, everybody working together. And obviously now the systems will have to, it was under the memorandum of agreement, understanding, but now the contracting needs to follow that now. So in terms of apprenticeships, I think that's what we are looking at, system-wide placements, but they are, whatever each of the organizations have put forward for, and you have to go, and AHPs, as I said, all this while has been difficult to come through, but in the last couple of years, we have shown the impact we can make. So therefore, I think it has started, and I wouldn't say it is started. I think it's a long way to go, but it's a start.
And so that, again, really helpful. And I guess, Gordon, it comes back to your point about the undergraduate training. I know that's moved on loads from when I trained, I'm sure, given the number of years. I've just had my 30-year long service award. So, for me, it's how do we do that from undergraduate level so that we're thinking about that, working across that interface and working differently, as well as how are we then bringing teams together. As Seema, you're absolutely right, the COVID response showed just what was possible. Let's just not go back to how it was before. I don't like the language of restoration and recovery, because we don't want to recover to where we were before. We can do better, and we've shown we can do better. So we should be moving forward to transform to what we can do better, not recovering to where we were previously.
I'm afraid that we've reached the allotted time for 8:30, where we're seeking to wrap this up. You know what? It's a good job that this isn't in the council house in Birmingham, because I think we'd be getting home at midnight. So this has been an absolutely fantastic session, and I think we really could stay till midnight. But unfortunately, there's a second half to watch at Anfield, so we need to let Simon get off. I think the three speakers have worked together extremely well in advance of this, and I'm so grateful to all three of them for how they've collaborated in putting on a fantastic session. This session would grace any Physiotherapy UK. It's been absolutely wonderful. I'd like to take this opportunity to thank Mindy as well for her support in hosting everything to do with the digital aspects of tonight, and also for Clare for her tweeting and all the other platforms that she's been busily putting stuff out on. So you'll be able to retweet and post your own messages after this. So thank you, Clare. Also thank Lorraine for going through the chat so brilliantly, and also the wider core team for the preparation for this. I'd like to take the opportunity to plug our next session. It's the 23rd of June, and we're working on a session around opportunities within the AHP field for physiotherapists. And what we've heard tonight is 3 physiotherapists who've put AHP first. They've introduced themselves as AHPs. And so the working topic title for it is AHP first or physio first. And so we've got Gordon Bigham come along. We've got Ash James, and we're also working on securing other speakers as well. So that's set up to be a really good evening also. So just to conclude, thank you ever so much to our 3 speakers. I'm indebted to all 3 of you, and look forward to seeing you on the 23rd of June for our next meeting. Bye everyone.